Before I introduce our next guest, I have a news flash from the Sacramento Bee. Los Angeles International Airport is now allowing travelers to carry marijuana. You don't have to hide it in your undies anymore. You can carry up to 28.5 grams and 8 grams of concentrated marijuana for personal consumption. Although after you leave the LA airport, I'm not exactly sure what will happen to you, but just a little bit there. Okay. I want to thank Tim for his presentation. It really sets the stage for our next speaker. Dr. Gene Santo is the medical director of the Interventional Pain Management Program at UPMC Pinnacle. She's board certified in anesthesiology and pain medicine. Dr. Santo brings a wealth of information, background, and experience in treating pain patients. I asked Dr. Santo to come and speak with us today about some alternatives to opioid prescriptions. And she's going to explain to us a little bit about medical marijuana, what it is, what it isn't, what it does, what it doesn't do, and some possible alternative programs that you might want to explore in your chronic pain patients. So without further ado, please welcome Dr. Gene Santo.
Thank you, Burke, for inviting me this morning, and thank you all for your kind attention. As Burke stated, I have a lot of years' experience managing chronic pain in the outpatient setting, both with medications and with various injections. Majority of my practice is spine-based, but I also do quite a bit of joint and soft tissue work as well. And prescriptions have always been a part of my practice, although you won't find that anywhere on my website because it's not something I've ever wanted or needed to advertise. So that's my background. And I've given this talk today the title of Medical Marijuana in Pennsylvania, or the subtitle Marijuana Anyone. And you'll see why I gave it that subtitle very shortly. The legal climate currently, when I prepared this slide in August, is as stated. 31 states and the District of Columbia allow the use of marijuana for medical purposes. In 9 states, it's legal. Some states even allow you to grow it at home. They usually have limits, but I know in California you can grow 6 of your own plants. So that's kind of odd for us to think about, but you know, so the climate regarding marijuana is very diverse. And I wanted to talk today about some issues of concern I think actually are interesting. One is that although we have legalization in a lot of states, it's illegal still according to the federal government. It's recognized as having no legitimate medical use. Furthermore, it should be clear to people, I don't think this ever gets the press it deserves, that there's really little or no good evidence for effectiveness for most conditions. All we hear about in the news and the press with the parents of epileptic children, cancer patients, HIV patients, when they talk about how effective it is, they're talking about anecdotal case reports, case series of 1 or 2 patients. There's evidence that it does work for pain. There's almost no evidence, good medical, strong evidence that it works for anything else. So keep that in mind also. Thirdly, it happens to be a very emotionally charged issue. I think we saw that firsthand when they were debating this at the Capitol. All the parents that came with their sick children, and so sometimes the facts are either downplayed or disregarded altogether in favor of emotion, and that's also something we need to keep in mind. Another concern of mine, particularly, is the safety of long-term use has never really been demonstrated. And the use in young people is particularly problematic, and I'm going to go into that further in the talk. Also, there's a big societal impact in terms of accidents, costs, and as it relates to you, lost work, impaired employees, accidents on the job. So there's a lot of issues that make this a very interesting and complex topic. So what are the nuts and bolts of medical marijuana as it stands in Pennsylvania? Currently, these are the qualifying diagnoses. If you have one of these diagnoses, you can get potentially certified to use medical marijuana in Pennsylvania. I copied and pasted this directly from the medical marijuana website, Department of Health. There's quite a bit of overlap. I don't know who wrote this list. I'm sure there must have been some lobbying because it's very sloppy. There's quite a bit of overlap. Neurodegenerative diseases is listed as one of the qualifying diagnoses, but about half of the other diagnoses on the chart are neurodegenerative diseases. So they could have probably eliminated about half of that list just by being more lumping versus splitting. I don't know who made the list out, but anyway, there's quite a bit of overlap. It's not nearly as complicated or confusing as it would first appear. It's interesting that they've chosen cancer, including remission therapy. So they don't mean that you can use marijuana if you're dying of cancer or you need help with your appetite. They mean if you've ever had a diagnosis of cancer. So that would include quite a number of people, right? If you've ever had a basal cell removed from you, if you've ever had any small cancer treated, you're considered cancer-free, doesn't matter, you can still qualify for it. I think the reason for that is not because they think you need it for appetite or palliative care. I think the reason is because in vitro studies, there's some evidence that there is an anti-cancer effect of CBD and THC. So that's been proven in vitro, in test tubes, and I have seen presentations, once again, just case reports of marijuana basically melting tumors. But there's no studies to that effect. But anyway, I think that's what they intended when they made the cancer qualifying diagnosis. What most concerns me is the severe, chronic, or intractable pain of neuropathic origin, it says, or severe or chronic intractable pain. So once again, a pretty sloppy description. But it's interesting because a few months ago when this was first published, it had a caveat that said, has not responded to conventional treatment. And that caveat is now gone. So what does that mean? Well, I used to, ponder, well, what's conventional treatment? And what's lack of response? I mean, if opioids work a little, is that good enough? Do they have to consent to surgery? Is that conventional? Can they refuse surgery? Can they refuse some things and still qualify for marijuana? So I used to spend a lot of brain power thinking about that. I don't need to anymore, I suppose. But it leaves open the question, is medical marijuana now a first-line therapy for pain? Because if you read that like it's written, it sure does sort of hint at that this is now a first-line therapy. And I don't know if we want to go there or not. I don't know if that's what's intended, but that's how it's written at the current time. So what's the process? How do patients get certified to use marijuana in Pennsylvania? Well, they go on the Department of Health website that I've listed here. It's all an online application. I don't think there's any provision to apply otherwise. They have to have information that exactly matches what's on their driver's license to a T. If their name is spelled wrong on the license, it's got to be spelled wrong in this database. So they're cross-referencing databases, all right? They have to have a unique email address. That just means they can't share an email address with another medical marijuana user, all right? And then they make an appointment to see a certifying doctor. The list is online, the Pennsylvania Department of Health Medical Marijuana website. None of the physicians are allowed to advertise their services in the state. I don't believe the dispensaries are either. So you have to go online every time you want information about this program. There's really nothing available elsewhere. Now so the patient does that. They go online, they register, they get a registration number, then what do? Well, they find a doctor in their area who will certify them, who they hope will certify them, and they make an appointment. The doctors have to have a valid license to practice medicine in the state, and they have to have passed an approved 4-hour course, and that is also listed online. So we pass that course, the results get forwarded to the Department of Health, and we're notified by email that we're now able to participate in the program. We see the patients, we interview them, we examine them, and we determine if they meet the criteria for medical marijuana. If they do, we complete an online certification, and the certifications can be valid for 30 days to 1 year. So we have an option to choose the length of time we want the certification to run. What happens next is the patient, once I do my online certification and I generate now a formal certification number, the patient gets an email stating that they need to pay $50 to the state for their card. If they have designated a caregiver, I guess the caregiver also gets some notification. The card then gets delivered in 3 to 5 days. That's this area of Pennsylvania. I guess we're pretty close to Harrisburg, so it's pretty immediate. And once the card's in their hand, they can go to a dispensary and they can talk to a pharmacist, and the pharmacist at the dispensary helps pick out products for them. So I always tell my patients to make an appointment to speak to the pharmacist because you don't want to go there and wait. I believe they limit the number of people they allow into the dispensaries, and so if you don't have an appointment, you might have to wait in your car. So I don't even think they allow family members in. It's the card-carrying member, and they usually go in with an appointment and speak to a pharmacist. I know some of the pharmacists here are actually part owners in the dispensary. They're extremely knowledgeable. At least the one that I deal with mostly in Enola is very knowledgeable. And what do they get? All right, they can get all kinds of things. It's a Sears catalog of marijuana. They can get pills, oils, topicals, gels, tinctures, liquids, or a vaped product. It can be a vaped oil, it can be a dry leaf. And this is a great representation of what the medical marijuana products are called. And you can read those for yourself. Wookie Cookies, Punxsy Punch. I like the Durban Poison. That's certainly a great medical product name. And I asked about this, actually. I was curious about why they were called these things. And I was told that there are 1,500 patented strains of marijuana currently in the nation, and that most of these were patented in states that allow marijuana to be legal for recreational reasons, and so you get these crazy names. However, I'm guessing that Punxsy Punch is grown in Pennsylvania and patented here perhaps, and there's clearly, it's not a medical leaning name. It doesn't invoke any kind of medical connotation, and so that leaves me to believe that the growers, the dispensers, the manufacturers, they don't intend for this to stay medical very long at all. They're all gearing up toward legalization of marijuana in Pennsylvania. I mean, that's the kind of assumption I would make just on looking at these names. There's not even an attempt to make it appear medical. They're just getting ready for the legalization. But it's kind of funny because the patients will come in for a follow-up and I'll say, what are you using? And they'll say, oh, I'm taking the green love potion. And they kind of put their head down and say, well, that's what they call it. You know, they're kind of embarrassed by it, the real medical patients, but nonetheless, that's what you get. And so you can see the process to get certified is pretty easy. I mean, anybody who's ever had pain, it's intractable, and that could be your basic chronic low back pain, you have a bad knee. Anybody who's ever had a cancer diagnosis, anybody who has diabetic neuropathy, for instance. So the only thing limiting you probably in getting certified for medical marijuana in this state is probably just lack of imagination. If you can't figure out some diagnosis for yourself, you know, because it's really here. Now, My practice, I tend to take a more medical view, and I review records, and I document prior treatment trials and things like that. But there are, coming into the area, I know there's one in Carlisle, these franchises, Compassionate something or other, and I know a physician that got a job working for them, and he was told that as far as they were concerned, everybody is suitable for medical marijuana certification. They don't need to turn down anybody. Now, they don't tell the doctor they have to certify everybody, but they say, as far as we're concerned, everybody is qualified to get certified. So you're basically getting now medical marijuana certifications for sale. They're not necessarily, there's not necessarily much of a bar at all to get these cards. So you should all be aware of that. It's a pretty simple process in certain hands.
Dr. Santo, on our next slide, what's the difference? Is there an app that people can go to sort of figure out the different types of products?
Yeah, there's actually, there's an app called Leafly, Leafly, and you can download this, and there are thousands of strains of marijuana products listed. And each of those strains has got a full descriptor on if they're pure sativa or indica or hybrids, what they're useful for, what their effects are, whether they're stimulating, sedating. There are reviews by users. It's like a Yelp for marijuana, and it's not just medical stuff, and it's nationwide. And I think there might even be pictures of it. It's pretty crazy when you see it. And when you read the reviews, it's pretty comical because they'll say, don't miss this chance to get stoned on this. It's pretty cool. And it's an amazing app, but it's got thousands of products on that you can review. But yes, so there's a lot of difference in the products, and those are patented strains. And that's the other interesting thing. So it's illegal according to the federal government, yet it's patented. All these strains are patented, so I don't really understand that process either. So there's a lot of contradictions in this whole process. But anyway, the products are variable in forms, they have different strengths, and they each have a different THC to CBD ratio, and that accounts for their effects. So we know that pain responds best to a 1-to-1 THC to CBD ratio. And we know that some products, because of the way they're used, will work very quickly. Those are the vape products. You vape them, they go from your lungs and the blood system right to the brain. You can get effects very quickly. However, the effects wane after about 2 to 3 hours. So if you were going to vape as your sole source of treatment, you would need to vape every 2 to 3 hours all day long, all right? So that's quick and effective, pretty potent, but not necessarily practical for some people. Pills, on the other hand, you ingest something, they might take 2 to 3 hours to work, right? But they'll last you 8 to 12 hours. So that sounds great, except that I've had several patients who have taken pills, and when they didn't get relief in an hour like they're used to with their other pain medicine, they've taken another 1 or 2, and then they've been incapacitated for a day or longer. I've had patients end up in the emergency room because they've incapacitated themselves on these oral products. And certainly if you have Crohn's disease or some other problem with absorption, the pills aren't going to necessarily be effective anyway. So there are vast variety of products, strengths, concentrations. It's an entire science. Let me talk just briefly about the 2 strains, because this is a little bit interesting. The cannabis indica strain is the relaxing strain, and that's got shorter, it's a shorter plant, bushier, and it's got a high CBD to THC ratio, so more CBD. It causes relaxation, muscle relaxation, it reduces nausea, it reduces pain, it improves your appetite, it increases dopamine, which is that reward chemical in the brain, all right, that we've all heard about. And so most of my patients, when they are prescribed this or a majority indica product, they're prescribed it at night, or not prescribed, they're recommended to use it at night. So, and most of the patients that I see when they come back to me for follow-up, they have a combination of products. They have a daytime product, and they have a nighttime product, and they have a breakthrough product with vapes, and so they're buying a lot of stuff. They're being recommended to buy a lot of different things. The sativa strain is the taller strain with narrower leaves. It says here it's anti-anxiety, yet it's stimulating. So you can tell when someone comes into my office for a follow-up on marijuana and they're taking sativa. They're very hyper. They've usually lost a few pounds. They feel great. They just feel great. And they love it. And I'm telling you, these people are achievers. They go back to work. If they're in college, they are doing well in college. They actually do pretty well. So what's my role as a physician? So before the patient comes to my office, when they ask for the appointment, I ask for records. And so I review the records. I want to make sure there's evidence that they do have a chronic condition. Chronic pain condition is my area of expertise. I want to see what they've tried, what's worked, what hasn't worked, what kind of opioid doses they're on if they're taking any, and what their concurrent medical problems are. And then if I determine that they're a good candidate for this or likely to be a good candidate, then I will schedule them, all right?
Doctor, can I ask you one question here real quick? Mm-hmm. If I, as a patient, have one of the enumerated conditions that sort of pre-qualify me, is that an automatic ticket to the clinic?
Not to me, it's not. Because certain things are contraindications. That's not necessarily true in the franchise clinics, but it is true in my clinic. So I would not certify anyone with a history of psychosis, schizophrenia, and I'll tell you why later in the talk here, why that's so. I would not certify anybody with unstable angina or cardiac disease. The products vasodilate. If you vasodilate, reduce the patient's afterload, you might trigger a heart attack or heart failure. I've had patients come in that have actually admitted to me they have been in jail for selling drugs. Turn that patient down. And there are some people that that have just contraindications in terms of they'll say they're allergic to a lot of things. I actually had a patient allergic to marijuana come into my office. That sounds weird, but I mean, I don't know how you could certify somebody who has a documented allergy to it. So yeah, they're definitely people that I would turn down. And that's why I look at their records beforehand. I don't want anybody to come to my office with the expectation they're going to be certified and then leave uncertified. I think that's fair because I'm going to charge for my time, and I don't want them to pay for my time if I can tell them ahead of time that they don't meet my criteria. I think if they go to a franchise, then they certify all comers. That's not really a problem, but it is for me. And it's important to recognize that we can make recommendations to the patient. There's a spot on the certification that I can recommend to the dispensary what they give the patient, but I tend not to because it's such a vast array of products. I feel the dispenser is more qualified and suitable to do that. Also, I like to keep my hands off of it, right? I have a federal DEA license, and I don't want there to be any hint that I'm actually recommending certain products. What I'm doing in my mind is I'm certifying that the patient has an enumerated condition, as Burke put it. That's all I'm doing. I let it up to the patient and the dispensary as to what they want to use and what they want to do with that. All right, so I don't ever want to be looked at as a person who's recommending marijuana because of my DEA. And it's important to realize that doctors don't prescribe this. All we do is basically sign a certificate online that says you've got one of these conditions. So if you want to go get some products, well, here's your card. But that's as far as we get involved, all right? And so how does it work? Now this is intriguing, I think, because God actually put marijuana receptors in our body. He put a whole system of them in our body. It's called the endocannabinoid system, all right? So there are receptors, CB1 and CB2, that actually respond to endogenous chemicals that our body has, anandamide and 2-AG. So these are like hormones, right? They're signaling chemicals in our body. And so our body has these chemicals coursing through them, landing on receptors, and then that triggers different reactions, all right? Appetite or reduction in stress or whatever. But those same receptors also respond to plant-derived chemicals as well. And those are called the phytocannabinoids, in which is CBD and THC. So those are the two most famous, but there are over 400 chemicals in each marijuana plant. But we only really talk about CBD and THC for now, although in the future we might find more effective chemicals. But for right now, that's what we're working with. I put the chemical structures of each of them up there. CBD and THC look a lot alike, right? They're isomers, which means they're mirror images, which means they look a lot alike, which means there's a lot of overlap also in their effects, because they're not necessarily specific for one receptor or not. So for those of you who like chemistry, that's a little bit. And so what do we know about how it works? The Health and Medicine Division of the National Academies did a huge report in 2017. They reviewed over 10,000 abstracts, and they came to the very vague conclusion that it has both therapeutic value and public health risk, all right? So that's not, it doesn't give us much to go on, does it? And the reason for that is that because they have all these abstracts, they're case reports, they're anecdotal, they're almost always based on recreational marijuana use, all right? Because there aren't any good studies on medical marijuana use. It's pretty much illegal to study this because you can't, it's illegal according to the federal government. So we haven't had any good studies. Secondly, the route of administration, the doses, the strains, none of that was controlled in pretty much any of these abstracts. So you only can make vague global statements that it appears to have some benefit and it also appears to have some risk. But the National Academy did say that it should never be a first-line therapy, which I thought was interesting, especially as it relates to that pain qualification, because that wasn't clear in the Pennsylvania law. So we do have 3 FDA-approved cannabinoids, and the 2 are synthetic, and but the last one is interesting. That Epidiolex, that is actually CBD purified directly from a marijuana plant, and the FDA has now certified that has legitimate medical use. So that, I think, is the FDA moving one step closer to saying that there is a legitimate medical use for marijuana, and that's a relatively new development. It's only approved for seizures, but I think that's an interesting direction. So, derived from the National Academy's report, we have some general blanket statements we can say about the effects of each of these cannabinoids. THC tends to be psychoactive, reduces nausea and vomiting, but improves appetite. It will reduce inflammation, it may treat addiction, and there's some evidence that actually improves the glioma's response to radiation. And as I say, they do have in vitro studies showing that there's some anti-tumorigenic effect of these chemicals. CBD, on the other hand, also can treat seizures, neurological disorders, anxiety, pain, inflammation. Cancer, once again, also can be an anti-infective and reduce blood sugar in diabetics. So it's interesting here that they each have some unique properties, but there's quite a bit of overlap, and that probably has to do with their chemical structures being similar, and so that they can land on similar receptors. So as Burke was asking earlier, there are some absolute indications for these products. In my mind, schizophrenia, is an absolute indication. We'll talk about why. Unstable cardiac disease, allergy, or if a woman's pregnant or breastfeeding, because you never want to give anything to any pregnant or breastfeeding woman, because you just don't know. Relative contraindications are liver, renal disease, pulmonary disease, the elderly, the young, people with seizures, strangely enough, people with addictions, they said. And you'll, I don't know, I didn't point it out, but on the Pennsylvania list of qualifying diagnoses, addictions is one of them, all right? So as an adjuvant to addiction therapy, we allow it in Pennsylvania, and they're concerned about in national academies, and so that probably has to do with marijuana's potential for addiction. So as you can see, once again, there are a lot of confusion in the marijuana world.
Doctor, you earlier mentioned that you find it very important to review a patient's medical records. Is there a concern of, I'll call it overlap of medical marijuana with other medications?
Yes, and that's my next point. So marijuana will synergistically act with any CNS depression, and we just heard it talk about these benzodiazepines, opioids, alcohol, antidepressants, and muscle relaxants would be another one. So you'll get a synergistic CNS depression effect. So in my practice, when I see a new medical marijuana patient, I check the PDMP database. If they're my current patient, I check that every time. If they're not my current patient but coming in, I check it. And I see what kind of doses they're on. My patients, I will tell them it's either marijuana or it's opioids. It's not both. And when you start the marijuana, we will gradually taper your opioids. And they get that. They understand that. If patients come to me from another provider and they are concurrently using opioids, I'll say, you've got to taper. And some of them say, yes, my doctor's aware we're going to do that. Sometimes, if those doses are pretty high, I'll say, I think I would like to taper you, because I'm not really convinced they're going to get effectively tapered by their primary care, who's ever providing. So I encourage the patients to see me for opioid tapering. Sometimes if they won't see me, I tell them I won't certify them, because I don't want people using high-dose opioids and the marijuana. Most patients to date have been pretty compliant with tapering, but I have some that will try to continue to use both. And so I had a person yesterday who continued to use the same amount of opioid 3 months into medical marijuana, and I said, is your physician who's prescribing, is he aware that you're using medical marijuana? Is he going to be tapering you? And she said, I don't know, I never told him I was using this. Now, I send the records to them, but, so you don't know if the doctor's reading them, and certainly not every patient is telling their doctor. So there's a great concern that patients are overlapping opioids or other sedatives with marijuana. And now this is an interesting fact. There's no way for me to know on the Pennsylvania Drug Monitoring Program if they're using marijuana. That database, I don't have any way to know if patients are buying the marijuana products. So although we talk a lot about wanting to control this, I can see on the PDMP what they're getting for opioids. I can't see what they're buying from the dispensary. Now, I think the dispensaries are hoping that, I don't even know if they can see what patients are taking opioids. So, that seems like a contradiction to me as well.
So are you drug testing them when they come to the office to determine if they are patients plus the opioids?
I am drug testing all of my current opioid prescribed patients on a regular basis. They're stratified according to risk, so they either get twice a year or whatever drug testing. When they come in to see me for medical marijuana, I have the PDMP, and so I know if they're on opioids. I don't really bother to drug test them at that time because I presume they're taking them. When they come back to me for follow-up, I'll check the PDMP. If they're still taking if they're still filling prescriptions for opioids, then I don't necessarily drug test them either, because I figure they're clearly taking them. So. It's stratified based on risk. So we do a risk assessment, an opioid risk assessment for every patient prescribed opioids. And it's the ORT, opioid risk tool. And so if they're low risk, we do it every 6 to 12 months. If they're medium risk, we might do it every 3 to 6 months. And if they're high risk, we may not prescribe at all. We may test every couple of months. We try to keep it random. Testing every month doesn't do anybody any good because it's so easy to beat that. So you have to maintain a randomness somehow. And we might call them in randomly or do pill counts. But yeah, we do everything on a stratified risk basis. So this is the part I think really gets kind of interesting, because whether you ingest this stuff or inhale it, it all goes to the brain, right? That's where it's effective. At least psychically, that's where it's effective. And so it goes to the brain, and it's important to keep in mind nobody's brain is fully developed until they're about 25 years old. So all of you parents in here, or young adults, just keep this in mind. When you hear all this on the news about how safe it is, I want you to remember this. When marijuana goes to the brain, it decreases memory, judgment, concentration and attention, reaction time, coordination, executive functions, attachment, behavioral inhibition, and even brain volume. Your brain volume is less when you use marijuana, all right? Particularly younger brains. It increases fear, anxiety, appetite, and sleep dysregulation, all right? And these things are going to be worse in a developing brain.
So, doctor, let me ask you this. Since most of these folks are dealing with the consequences of persons who get injured on the job, what are the possible ramifications for an employee or for an employer dealing with an employee who is utilizing medical marijuana?
Well, for one thing, they could have trouble on learning new jobs, right? Learning problems, impulsivity. We have probably they're going to be more prone to accidents in their car on the way to work, or in one of the work vehicles, or anything at work. They'll be more prone to accidents and falls. They might become aggressive, anxious, and exhibit poor judgment. Socially as well, because it can cause isolation and lack of attachment, people can, young people particularly, can start having very promiscuous sexual behavior. They can withdraw, become isolated, and they can start gaining weight and having sleep disorders. So, that 25-year-old kid with, Cheetos on his fingertips, living in his grandmother's basement, I mean, that's what you get. That's what you're flirting with when you start using medical marijuana any marijuana at a young age, And I don't know if any one of you want these people employed in your business. So to me, they present a lot of risk if they're going to be using marijuana while they're working. Now, I have patients that tell me they don't use it if they're going to drive. They don't use it at work, before work. They only use it after work or at bedtime. So I don't know how much they're going to be effective. That's going to be pretty individualized. I have some patients who tell me they work on it and they work just fine. I'm guessing that's that sativa crowd, right? Because they feel great. Yeah, I think there's definitely a reason to be concerned about using marijuana on the job, or just using it generally in the workforce. I have a few statistics here that I thought would be of interest. And this is what I was talking about the psychotic patients. The risk of psychosis in the general population is 3%. When you look at occasional marijuana users, the risk increases by 40%. It's 390% increased risk for regular users of marijuana. 390% increased risk of psychosis in medical marijuana, in marijuana users in general, medical or not. Because medical marijuana is no different from recreational marijuana. It's just certified, right? Half of those people develop a chronic psychotic syndrome. I think that's a stunning statistic right there. 1 in 9 users will become dependent, and the younger you start to use, the more likely you are to become dependent on marijuana. It's documented that IQ scores drop 10 points for adolescent users, and that may not be reversible. So All the hype you hear about marijuana being safe and not a problem, and it's not quite as advertised. There's a nice book called 21 Myths About Marijuana. It's written by a physician in Canada, and it's written for young adults and teens, and it very nicely goes over some of the myths about marijuana, and it debunks some of the statements that people have made about it being so safe and, benign. And I would suggest if any of you are parents, you would want to get your hands on that book and show it to your children. There's a 3% increase in motor vehicle accidents in states with legalized marijuana. And drivers under the influence of marijuana are twice as likely to be responsible for accidents as sober drivers. So that's something to keep in mind for your workers as well. On the other hand, this is very interesting. Published in JAMA 2014, the only significant correlation with reduction in overdoses from opioids was the enactment of a law allowing access to medical marijuana. So intriguing, the PDMP, increase in state oversights of pain clinics like they do in Florida, employment rates, nothing had an impact on reducing overdose rates except access to marijuana. So, all right, it's not all bad. And we're gonna see again that this is another peer-reviewed journal, medical marijuana legalization users reported reduced hospitalizations related to opioid use or opioid dependence. So now we have another great thing. They also reported a 64% reduction in opioid use and a 45% improvement in their quality of life scores versus opioid users. So we have amazing positives and negatives on this marijuana teeter-totter. And this I found very interesting. I happened to come across this recently. Mark Wallace, he's a very big name in pain management. He's at USC San Diego. He's actually now recommending marijuana before opioids to patients in whom other therapies have failed. So that to me is intriguing because now it's become a first-line therapy in the hands of a very prominent pain physician and researcher at a prominent institution. It's now considered first-line therapy. So that's medical marijuana in a nutshell. I hope I've touched on enough of it to answer some questions, but didn't get too technical with it really. But it's an intriguing topic. I think with a lot of politics involved, a lot of emotion involved, a lot of uncertainties, and I think we're just starting to see some of this in Pennsylvania. I expect that in the following years, I'll be interested to see how it develops in terms of costs in the workers' compensation world, motor vehicle accidents, and other areas. Burke did ask me to talk briefly about tapering opioids.
Yeah, and I wonder if we could just set the stage for that real quick. I did ask you, doctor, whether medical marijuana is overall less expensive than opioids. What's the story on that?
My experience with patients, when I poll them each time they come in for follow-ups, they have told me that they pay about $150 a month, most of them. Some pay over $300 a month. I have one patient who told me they paid less than $100. I'm gonna guess between $150 and $200 a month is about average for my patients to spend. So if you compare that with the total cost of opioid therapy or other pain therapies, maybe including Lyrica and whatever else, I think you'll find this is less expensive. Interestingly as well, what should be considered is many of my patients have not only stopped opioids, they have stopped anxiolytics, they have stopped adjuvants like gabapentin or Lyrica, they've stopped NSAIDs. So it's not just a one-to-one opioids and marijuana. The marijuana seems to actually cover a wide gamut of products, including sleeping pills. So the concern about sleeping pills, opioids, and benzos and muscle relaxants all being together, now we can conceivably in some patients bundle all that into one medical marijuana product.
Well, that then segues into the topic that I did ask you to speak on, and that is if we have employees who are, I'll say, addicted to opioids, is there some type of mechanism, medical marijuana or otherwise, to taper folks off of the opioids?
Yes, so that's not hard at all. It warrants one slide only. Let me be clear. People who are taking opioids long term are certainly dependent, right? If you stop them suddenly, they'll go into withdrawal, all of them. They're addicted if they have more of a psychological component, a compulsion to use. I like to keep that distinction in mind for my patients particularly, because I don't want to have my patients feel labeled, discriminated against, or consider themselves addicts. I think they get enough abuse when they go to the pharmacy every month for their opioids. I just like to make that distinction. They are dependent, all of them, and some of them are addicted as well. But sure, we do this every day, all day in our office. We taper people from opioids, whether they tell us they don't want to be on them anymore, whether we assess that their pain scores are still high and the opioids aren't working, so we say we're going to taper, whether they are referred specifically for tapering, whether they're medical marijuana process, and we have a tapering plan for whatever reason. We do this every day in our office, and we use a couple simple criteria. That is, we reduce the dose by 10 to 20% each month. We go slowly. We don't do it sooner than that because, number one, it just is, it's just harder. The faster you go, the harder it is. And if some of these patients have been on the opioids for years and years, doing it quickly is not necessary. It just makes it even harder for them. And so we go very slowly, and the longer they've been on it, the slower the taper. Toward the end, we go even slower. That we've always had success. Always had success. If the patient wants to come off, we always have success. We have success even if they don't want to come off, because we just say no. When they come into us on high-dose therapy, we don't prescribe high-dose opioids, but if they're under my care and they're getting high-dose opioids, they come in for marijuana and I need to taper them, they'll argue with me and complain about how they need both, and I'll say, I understand, I see, I understand your point, and the next prescription will be for 10% less. And if they continue to argue and complain, I'll say, well, listen, this is my plan for you, it's what I think is in your best interest. If you don't agree with me, you're more than welcome to go find another physician that will prescribe these opioids, and almost never is that possible, because nobody wants to do this work anymore. So we just say no, they're going to be tapered, and they taper. And if we do it slowly, we don't have problems at all. They have minimal withdrawal symptoms. We get everybody down. We seldom have a problem. Benzos are a little bit harder to get people off, especially toward lower doses. But honestly, it's a very, very doable thing to get people off opioids. And it shouldn't scare the patient, it shouldn't scare the doctor, and it shouldn't scare any of you as managers for this case. Yes?
Do you find that patients would be resistant to medical marijuana because insurance won't pay, whereas they'll pay for opioids?
Repeating the question is, do you find that
Patients could resist the medical marijuana because of the cost? Insurance will pay for opioids, but they won't pay for marijuana.
Could everybody hear that? Okay.
Yeah, so I don't ever recommend medical marijuana. I allow the patient to bring it up because I don't want to be viewed as advertising or pushing it. So I'm very careful to not recommend marijuana, except if I maybe say, here's your list of options, but I never make a recommendation for it. But some patients do choose to not go that route because of the cost. Absolutely they do. Yeah, it's not cheap. I mean, for the patients, it's not cheap because they're getting their prescriptions for $20 a month. So medical marijuana is a big step up. I mean, for the insurer, somebody paying the cost, I'm sure it's cheaper, but yeah.
We're going to switch to the final gear. Gene's giving me the high sign here.
No, I want you to have microphones. This is the code of silence here in terms of communicating. If you have a question, I'll throw the microphone to you.
All right, thank you. Now, we're going to switch gears into another subject which is quite fascinating to me, and that's the issue or the concept of interventional orthopedics as opposed to surgical orthopedics.
Yes.
And with that, doctor, can you tell us about the program that you are developing and working with?
Yeah, so my current practice, Advanced Pain Care and Biohealth, is now doing interventional orthopedics. And I wanted to introduce this to you because it's new and it's potentially going to be very important for work injured patients and their insurers. And I believe that it will in the future replace a lot of elective orthopedic surgeries. So I wanted to introduce it to you and tell you about how it's going to be available here in central Pennsylvania. It began in 2005 when Dr. Centeno and Schultz started the first clinic on earth treating orthopedic conditions with isolated stem cells. And they pioneered Regenix, which is the most advanced orthopedic stem cell and platelet procedures in the world. And they do it differently than the run-of-the-mill PRP stem cell clinic because they have their own process for isolating the cells and re-injecting them. This process of using biologics to heal injured tissue is called interventional orthopedics. It's very new, particularly to this area. And it basically is injecting biologics to facilitate healing of bones, tendons, muscles, and cartilage. It's the precise placement of those injectates under fluoroscopy or ultrasound into the damaged structure. And it's not taking out a meniscus, right? It's not necessarily sewing together tears or operating, right? It's actually healing structures. So you can do a simple, to date we've done simple joint injections. You just inject into the hip socket, the knee joint, or the shoulder joint. That's on one continuum, and that doesn't work. To date, we've gone all the way to the other side of the continuum. We've offered surgery, but there's a huge middle area of interventional orthopedics. There's less than 1% of the physician population in the United States trained in it, and I'm trained in it, or a lot of it right now. And interventional orthopedics, you can actually target and isolate injections to damaged tendons, ligaments. You can regrow cartilage in certain conditions. So you can pinpoint the damaged structure, you can inject stem cells or platelets, and you can actually heal those structures. So it's a way to preserve the joint, to heal something, and not actually operate and take things out. You can treat head to toe, everything from headaches to neck pain down to the ankles, everything in between. I like the Regenix method. That's my current affiliation because they only allow highly trained physicians to perform their procedures. Everything is done with guidance, either ultrasound or x-ray. The cells are custom processed in a lab on site. And I currently have my lab on North 36th Street here in Camp Hill, where I'll be doing the procedures. And there's actually a research facility in Denver where they actually study different cell counts and different procedures, so we get hard and fast data that something works. We know what cell count to use, we know where to put it, we know what duration they're going to work for. We have a lot of evidence to back this up. And to give you an example of what interventional orthopedics is, we have there on the right, lower, an MRI of a knee. That bright thing in the patella up above is a bone marrow lesion. In the upper right, you see a trocar going into that bone marrow lesion, and you can inject stem cells and actually heal that lesion, all right? And the needle is going into the joint space to regrow putting stem cells in there to regrow some joint cartilage. So you can do that under fluoroscopy in an office, and you can actually heal those things. That is an ACL being healed, and if it's a severe tear, it can't be, but more minor tears and strains can definitely be healed. Shoulder labral tears, that's actually a small video of injection into a slap tear. And this is an image of a hydrodissection of a median nerve. So it's a carpal tunnel patient getting hydrodissection of the median nerve for carpal tunnel syndrome. So I hope to see it replace a lot of elective surgery because it's less invasive, there's faster recovery, and it preserves biomechanics. So this is an example I like to use. So if you see the tall ships come in, right, and they have those masts that are going way far, way high in the sky, what holds them up? Well, there's rope, right, that tethers them, and that's what holds them up. Same thing happens all over our body. Think of the spine. The spine are just bones stacked on one another. The ligaments and muscles surround the spine actually support it and tether it. When you have laminectomies, invasive surgeries, and you're cutting into all those muscles, you've just destroyed all the support for the spine. So of course, they're going to have post-laminectomy pain, they're going to have degenerative scoliosis, they're going to need progressive fusions to help support the spine because you've destroyed all the ligaments and tendons and muscles that have been doing the work. So if you can, and that same sort of concept, it can be used around the knee or the hip or the shoulder. So if you can preserve those biomechanics and not take away all the support for the joints, and you can heal them at the same time, you've done your patients a great service. You haven't resigned them to a lifetime of progressive spine fusions or joint surgeries, and hopefully, for your interest, you've saved some money. What do we inject? We inject platelets. We take bone marrow out and spin down and get the stem cells, inject those. And those are primarily what we inject. There's a lot of hype this day about stem cell procedures. And I want you to be careful about it because some people will say, oh, it's magic, it'll just treat everything. The Regenexx method is kind of more, well, let's see what works. We like to do evidence-based medicine. And I want to talk to you one thing about this amniotic fluid, placental or cord stem cell hype that you'll read about online. They talk about live stem cells. There are no live stem cells in any of those products, all right? They're dead tissue. They have to be. They're radiated to be safe, right? To take out all the viruses and things. They radiate them, they kill. There's no live cells. So the FDA regulates them as dead tissue products. They are dead cells. So there's a lot of misrepresentations and hype out there. That's why you want to stay with somebody you can trust, because you can spend a lot of money on these procedures and get very little back. Sometimes these procedures are performed even locally in a chiropractic office by a physician's assistant or a nurse. There's not necessarily guidance being used. They'll just shoot some platelets into a joint and call it good enough. And so you really want to be careful who you send your patients to. You want them to get evidence-based medicine, the best of care. And I'll answer any questions I can on that as well. I hope I've given you some good information today.
That's a lot of stuff to digest. Dr. Santo, thank you for your presentation. Will you be available to answer questions perhaps at lunch?
Yes.
Okay. Thank you so much.
Another shorter break, and then we'll come back and then we'll morph into the employment environment regarding